can't hear you.
You're recording? Yep, perfect. Can you move a little bit to your probably left, I imagine?
This way?
There we go. Yeah. All
Yeah,
right. And we're live. Let's see here. All right. Nice, guys. We got people join in. Those who are live with us right now are just waiting for Dr. Renaud to join in. He's just running a little bit behind. So Dr. Rose and I are going to get things rolling for you good people. First, let's do a little bit of introductions and just some disclaimers that we have to do. First off, my name is Cole Siever. I'm one of the co-founders of MedMatrix, help out with marketing and a lot of the things here. And I'm joined here by the fantastic Dr. Rose. Dr. Rose, why don't you give a little background of your kind of expertise with Lyme disease and yeah, in your experience just in functional medicine.
Yeah. So my name is Dr. Sasha Rose, and I've been practicing functional medicine for over 20 years now. All of that time has been in Maine and New Hampshire, and it's difficult to practice medicine, especially functional medicine, for that length of time without having patients with acute and chronic Lyme / tick-borne illnesses. It's just endemic, unfortunately, to this part of the country. So, yeah, I've seen people in all stages, I guess. Again, from people who just got a tick bite to people who have been dealing with latent or chronic Lyme for 20 to 30 years. So it's something that we are kind of, for better or worse, kind of forced to become well versed in, I guess, just by the nature of where we live and the way that these tick-borne illnesses have, I guess, spread and just how debilitating they can be. So I think it's a really important topic. It's a complicated one, which, probably many of our viewers and listeners already know, but hopefully we will be diving into that kind of why it's complex, everything from the clinical presentation to the testing to the treatment, and ways that Dr. Renaud and I have found to, I'm not going to say simplify the process, but at least try to bring some clarity along the journey and improve people's lives, people who are dealing with Lyme and co-infections.
Gotcha. Okay. Would you mind switching your audio to the MacBook, not your microphone? I think there's a weird feedback. I don't know if you guys can comment if you're just hearing the same feedback that I'm hearing. Just on the microphone. Just click the microphone button and then you should, if you can't figure out, no worries. Leah will take care of it.
I need Leah. Okay. You mean to turn this off? You mean to turn this off?
No. Okay. Just let Leah take care of it. We're all good. Okay. All right. So let's give a little more context. We're waiting for Dr. Renaud. What is the difference between a functional approach to Lyme and a conventional approach?
So I guess I'll back up a little bit. At least until recently, I don't know if this is changing or not. There is not a lot of awareness in conventional medicine around Lyme disease, around recognizing it, around the fact that it manifests so differently in different people, and that the co-infections, which we're going to get into, also present differently.
Right.
And so it's often missed. It's like a missed diagnosis. And or in conventional medicine, if somebody doesn't show up with a bullseye rash, they get blood work, which is kind of insufficient or not timed correctly, and that's negative, then they're told that you don't have Lyme disease. And or if they are given anything, it's a very short course of doxycycline, which is kind of the standard of care antibiotic. Right. And then that's it. And so every step of the way, from recognizing the symptoms to the testing to the treatment, is limited at best in conventional medicine. Again, this is a complete generalization. And I think it's not necessarily bad intentions on the part of the providers. It's just lack of information and lack of training. In functional medicine, we are trained to look at the whole person, and we just, I'm going to make a bold statement, we just do a better job of looking at these conditions that affect multiple systems, right? So the nervous system, the musculoskeletal system, the immune system, all of it. And that's
Right.
that's one thing that makes Lyme and tick-borne illnesses so complicated. And we do take that step back, and we aspire to piece it all together and to say that, that recurrent migrating joint pain actually might be connected to the fact that you're not digesting your food as well as you used to. And just because you don't remember finding a tick on you doesn't rule out the fact that this might be Lyme disease or a tick-borne infection. So again, I think hopefully within functional medicine, what most of us are doing are stepping back, looking at the whole person, piecing it together. If there is testing that we feel like is warranted, we will do it. There's also a big difference between acute and chronic Lyme, and our bodies are complicated, and sometimes a Lyme infection is going to trigger, I guess, some underlying things, whether it was an autoimmune condition, a mast cell activation syndrome tendency. It's going to kind of trigger these other things that were there, and we aspire to be good at kind of tying all those together.
Gotcha. Got a lot of questions from what you just said. All right, we got Dr. Renaud. Hey.
Sorry.
Hey.
Perfect.
Sorry,
all right, well,
I
I'm
was
gonna
having some technical difficulties with my camera. Sorry, guys.
No worries, we're here and all is well. All right, well, let's kick things off for real. Doctor has already got us started with some great context. We covered kind of the basis of conventional versus functional approach to Lyme disease. Now we're, in today's webinar, we're going to dive into everything from the testing that's different, kind of the approach and how we treat it, to strategies. Hey guys, we appreciate you saying hello. If you're joining us live, shoot us a comment. Tell us where you're joining from. We'd love to interact with the audience. Yeah, tons of exciting things. So Dr. Renaud, Doctor has already given an intro, but why don't you kind of introduce yourself and your experience with Lyme disease?
Sure. Yeah, I'm one of the providers at MedMatrix. I've been practicing functional medicine for about 10 years. I have broad spectrum board certifications and fellowship training in functional medicine. I actually have been formally trained and am a member of ILADS, which is the International Lyme Association, and I've actually spoken at one of their conferences. So from a Lyme perspective, what we're talking about today, I've been treating and studying Lyme for many years. So it's something I have a lot of experience with.
Right. So let's start us off with a good question that Doctor has kind of touched on, which is Lyme being systemic, more than one issue. Like, why is Lyme more than one system? Why is Lyme actually a systemic issue?
Or multi-systemic.
Multi-systemic. Yeah, I mean, one of the biggest issues with Lyme is the way the immune system responds to it. So if we can maybe back up a little bit, I don't know if you guys addressed this already, but sort of like what Lyme is. Lyme is a bacterial infection, specifically a spirochete, that is transmitted by a bite of the infected black-legged or deer tick. And the literature is really mixed about how long ticks have to be attached to you before infection is transmitted. There are many resources that say transmission is really low, less than 24 hours if the tick's been on you. There's new research to disprove that. So the issue really becomes Lyme is like a chronic issue, and that's where we can get this sort of multi-system approach. So chronic Lyme can really affect the body in multiple ways, from chronic fatigue to brain fog to joint pain. A lot of people get memory and cognitive issues. They can get a lot of neurological issues, Bell's palsy, which is facial drooping, heart issues, depression, anxiety. So because there's such a systemic involvement with this, it can really be multifaceted in terms of symptoms. And that's unfortunately where patients struggle, because it leads them down a lot of different roads. They have all these different symptoms all over their body, and they see a specialist for each one, and no one sometimes puts it together. Or they get tested for Lyme and the test isn't accurate. It's not great. We can talk about that more too, sort of the downfalls of testing. So it can really send patients into a long medical spiral, sadly, which we talked about a lot of conditions on this podcast that happens too. So that's really the multifaceted chronicity piece for sure.
Gotcha.
And we don't really know why. We don't really know why that is either. It's sort of similar to like this whole long COVID issue that we've talked about on the podcast too, is what sort of is going on that's causing the body to behave this way over a long period of time. Is it that the bacteria hasn't been eradicated? Is it lingering immune response? Is it both? Is it some sort of other condition that the patient has? So there's a lot of things to consider here.
Gotcha. Couple quick questions again to lay some groundwork here. What is the difference between kind of conventional testing for Lyme disease and functional testing for Lyme disease? What you would do at a place like Med Matrix?
Do you want to say that answer, Dr. Rose?
Yeah. So I kind of said earlier. So sometimes what somebody will get is they'll get, and again, this is often with like an acute. If somebody goes to urgent care or maybe to primary care, they will maybe get an ELISA test, maybe a Western, and then maybe followed by a Western blot test. The timing matters, right? Like Dr. Renaud, you can correct me on this, but basically it's like if you're not catching it kind of at the right time, you might be testing too quickly. You might not catch it in time. And if it's like a longer, it's not acute anymore, right? It's been past a few weeks. You're also going to miss a lot of it. And unfortunately what happens is that most conventional providers are trained to just rely on that. And so if that blood test comes back negative, if somebody's ever, and they only get it tested once, and then they're basically told, nope, it's like, that's it. End of story, right? End of discussion. I don't know if I don't know if there's usually any other testing done. Do you? On a routine basis?
No, not on a routine basis.
In a conventional model.
No. In the conventional model, as you said, most of it is Western blot or ELISA testing, which, to be specific to our audiences, testing that's utilized to detect antibodies. So basically, is the immune system producing a molecule that we can test for, that the immune system has recognized the foreign invader, right? The bacteria. There's a couple problems here, and this is where some of the most recent literature comes into play of Lyme testing and just Lyme disease in general. So stop me if I'm getting too technical, but the spirochete, which is called Borrelia burgdorferi, which is the scientific name of Lyme, it utilizes a variety of strategies to evade and suppress or manipulate the host's immune response. Basically, it Harry Potters itself with an invisibility cloak from your immune system.
You didn't just make that up.
No, yeah, I did. Maybe I said that to a patient before.
I like it. I'm going to
basically, Lyme disease, the bacteria can invade your body, and it can hide itself from your immune system. So your immune system doesn't even know it's there. So when the conventional tests, like the Western blot and the ELISA that you're speaking of, is done in this situation where, okay, I'm a bacteria that I've put an invisibility cloak over myself, I can't be seen by the body, the test is useless, totally useless, right? Yeah. And the other issue is, which we can get into, is the issue of co-infections. So a co-infection is not Lyme. It is a separate infection that is related often to Lyme, transmitted via tick, but is a totally separate family of infection. So if you're getting a Lyme test, you're missing the co-infections. And in all honesty, there are different subspecies of Lyme. So when you do a Lyme Western blot, it's just for Borrelia burgdorferi, which is the traditional standard Lyme bacteria, but there are others. So if you just get that Western blot, you're missing co-infections, you're missing other forms of Lyme. As Dr. Rose very, very importantly said, if it's very acute, right, you had the tick bite yesterday or last week, maybe you'd get a positive Western blot, but you might not because of the way the infection works with the immune system. So, and this is not something we're making up, right? This is very, very well documented in the medical literature and in infectious disease medical literature. This is not some like woohoo, alternative medicine, functional medicine journal that has no credibility, right? These are very, very credible top medical journals that are published about Lyme and the pathophysiology of Lyme, but clearly no one's reading them. So they don't understand the pathophysiology of Lyme, so they don't understand how to test, and then patients go undiagnosed. So
do you know anything about the C6 peptide ELISA test? It's like supposed to have a stronger early sensitivity.
It's supposed to have a stronger sensitivity, but according to the data, those tests are not like the gold standard in infectious disease is FISH testing or fluorescence microscopy, which basically means you are taking a blood smear and examining it under a microscope, looking for the infection on the red blood cell. That's the gold standard. So why is that not done routinely? I've asked that question almost every patient I've treated Lyme. Why don't they do this? Well, they do it for almost every other infection in the hospital, right? They're doing those types of microscopy analysis for pneumonia and for sepsis in hospitals. Why aren't they doing it for Lyme? I have no idea. I think it's a money problem. And it's also a recognition of Lyme as an actual disease.
Right.
Part of the medical community, the CDC, the American Medical Association, does not recognize chronic Lyme as an actual thing. And it's refuted by certain medical entities. So they're not going to advocate for proper testing in hospital settings because they don't believe it's a thing. So that's where a lot of the pitfalls come from.
Absolutely. I mean, I don't know if it's just kind of around here, but I know, like, you would think that infectious disease would specialize in Lyme and tick-borne illnesses, and at least what I know of kind of anecdotally is just the opposite, that people,
total opposite.
If they go to infectious disease, they're dismissed.
Yeah, and that's the real sad part is the literature and the pathophysiology of Lyme supports so much of what we're talking about and how difficult it can be to detect and, what the proper testing is, but patients are still just shunned. Like, nope, your test is negative, get out, it's not that, go see your primary, go somewhere else, you don't have Lyme. I think it comes back to something we talk about on this podcast almost every episode is it's just a systemic healthcare problem. That's what it comes back to. It's just another example of a systemic healthcare problem where a provider does not have the time or the resources, nor maybe the energy to go deep in investigation. Luckily, there are Lyme specialists all over the country and all over the world, but they're not always easy to access. They're not, you can't, find a Lyme expert maybe if you live in a rural town and, part of the world. So it's tough.
What's your go-to, like, say somebody, not for acute Lyme, but say somebody comes in and they suspect chronic tick-borne illness.
Yeah.
What's your if you have one, like a go-to test?
They need FISH testing. So FISH testing is done through IGeneX labs, through T Lab. I think those are the most popular two that I've used.
I'm most familiar with IGeneX, but it's good to know that there's another one too.
Yeah, there are others, and they're trying to perfect the technology and also perfect the technology of testing for the co-infections, not just Lyme itself. Right. So, yeah, but again, these tests are not covered by insurance. They're thousands of dollars just for the tests. So that's a barrier right there, right? Absolutely. If I say to a patient, like, you really need this test, but it's going to cost you $2,800, and it's like, oh, I can't pay for that. It's like, well, I don't know what to tell you. It's just another, but the test is worth the price because it gives answers, and the test cost is because of how involved the testing methodology is, right? It's very specialized. Mm-hmm. But again,
it's literally someone taking your blood, like one-on-one, looking at it under a microscope.
Right. It's very, very specialized with a very, very specialized pathologist that's got to do this work and has to understand the mechanisms and the pathophysiology. But you'd really think that an insurance carrier would want to understand this, but I'll be honest, and this might be a little bit of, not believed by many in the medical community, but I think the medical community shuns Lyme patients because if we recognized chronic Lyme, it would be a whole other millions of people across the world that we would have to understand how to treat them. And the medical community doesn't know how. So they just shut them up and get them out of their office so they don't have to recognize that it's a problem. And I hate to sound so negative, but I think it's just a huge systemic issue with the healthcare system. If we don't recognize these patients, they don't exist. And that's not fair, right?
Right.
So
yeah. So let's talk about obviously it's not understood to the same level that other, things are in medicine, but you definitely get a heck of a lot better care when you work with providers like you guys. So when a patient does come in and you do realize, because it sounds like first big issue is that they just don't even detect Lyme disease. They're not doing the right testing. They're brushing these patients off. They're definitely, correct me if I'm wrong, but it sounds like conventional medicine is never going to bring up oh, hey, maybe you have Lyme. Or am I wrong?
Rarely. Maybe. I think if there's, of course there's going to be some educated conventional providers who will, but I think that's probably the exception. And a lot of it, again, is maybe just lack of training, lack of awareness, and lack of time in the visit.
Mm-hmm.
Yeah.
At what point do you guys recommend a Lyme test? Because, I'm sure you see a lot of complex patients who have symptoms that could be attributed to Lyme. You say, oh, this looks like Lyme symptoms. But again, yeah, it's a pretty pricey test, and there's so many other avenues you can go. So when do you guys feel confident saying okay, we should do a Lyme test on this patient?
I think to your point before, I think there are some conventional and even infectious disease or other specialists who do test for Lyme, but again, they're taught in school, you do the Western blot test. If it's negative, they don't have Lyme. End of story, period. Or if they do get a positive test, oh, well, here's doxycycline for 2 days and you're cured. So that's the other problem, is what we call post-treatment Lyme disease syndrome. Basically, persistent Lyme symptoms despite treatment, but maybe they weren't treated enough is really the problem. So I think conventional providers do treat based on suspicion, but again, there's some hard stops, right? Oh, you did doxy for a week? Oh, you don't have Lyme.
Good.
You were cured. You're good. So all your problems are in your head, right? It's well, okay. So I think patients really have to be looked at very carefully with symptoms, right? Where they live, are they outside? Have they ever had a tick bite? A lot of patients who've had Lyme and that I've treated for Lyme have never had a tick bite. I've had patients oh, I've lived in New York City my whole life. I've never had a tick bite. No, that's not a thing. And a lot of times the most common way that Lyme is transmitted is by the baby ticks. They're called nymph ticks, the little tiny ones. They're if you take a ballpoint pen and put a dot on a piece of paper, that's how big it is. So if it's in your hair, if it's on your back, you'd never see that. And if you don't get a rash, the classic bullseye rash, then you might not ever attribute that there was a problem. So patients really need proper screening. They need to be asked about where they live, where they've lived. Do they have dogs? Do they have animals? Do they live in a wooded area? What part of the country do they live in? But this whole notion of, oh, I live in California. There's no Lyme in California. Crap. That's total false. Oh, I live in the UK. There's no Lyme over here. Yeah, there is. Ticks travel on things, on cargo, and I've treated patients with Lyme all over the world. So this notion that this is just a Northeastern problem is not even true. So I think more patients need actually to be tested if they fit certain criteria.
I think there's a big education piece around it of tick bite prevention. So that kind too. Of like you're saying, the bite, it can be the nymph can be so tiny it can hide in the genitals, it can hide behind the ear, it can hide in the hair and hairline, and that the misinformation, one, that you have to have a bullseye rash, and then there's still people that feel unless you're walking through tall grasses, you're not at risk. But around here, how cold the winter is going to change the tick population in the spring. you know, how wet the spring is and the fall is, that's going to change. And so, and you're right, they can come in on animals. Absolutely. So
yeah. There's, you know, if we're talking about people that need to be evaluated, right? Some of the acute issues are acute flu-like symptoms is really the most common thing. So fever, chills, fatigue, severe headache, swollen lymph nodes, muscle pain. So, you know, something like that might be looked at as a flu, but say you get that in summer, well, that doesn't make sense, right? But now that we have COVID, it makes it a little harder because it's like, oh, well, we have COVID. But then really, as I was mentioning earlier, some of these chronic multi-system issues of fatigue and brain fog and memory issues or, you know, anxiety, depression. If patients have multi-system issues that affect their function, affect their day-to-day, how they think, how they physically can move around their world, you really need to assess for this. It's really important. Yeah.
And I think oftentimes with the joint pain, it's often like migrating, right? So it kind of comes and goes. It's not like this one, you know, like a shoulder that's just kind of from overuse and it's kind of always there and it's one joint. Like it'll often migrate from joint to joint and it'll come and go. Again, which can also be like several connective tissue autoimmune disorders. So
sure. Yeah. So sometimes your differential diagnosis gets really long. Yeah.
Man, you guys are giving me the heebie-jeebies talking about lymph.
Yeah, a little bit.
I have patients. I mean, I have patients who are honestly really scared to go outside unless it's this time of the year. You know, unless it's like the ground is covered with snow. They themselves have been bit. They have somebody who's been really debilitated by chronic Lyme, and it's unfortunate that they have that fear.
Yeah, geez, that's almost.
Don't ask me to go hiking. I won't go.
Really? Because you're scared.
Is that right?
100%. Yeah. I mean, I go outside. I do outdoor things, but to go,
it has to be on concrete
in the woods. You know, I've treated patients with chronic debilitating Lyme. Don't ask me to go. I won't. I'm not. Nope. I'm good. Sorry. You know, when you're a Lyme specialist, there's certain things you just won't do. So that's one of them for me.
Yeah. I guess. I mean, I'm pretty blown away by how, I guess, poorly Lyme is being treated in conventional medicine, and then the kind of how debilitating it can be. I guess let's start talking about like the root cause approach. Like, how do you guys actually, like, how do you even fix Lyme? Like, how do you help a patient get better?
I think it's really nuanced, and you know, there's
why is it? Well, I guess before we get into that, why is treating Lyme so nuanced and not as simple as just, hey, take doxycycline?
So if it's like relatively acute, yeah, there probably will be, you know, doxycycline probably does make sense, but as Dr. Renaud said, it's for usually more than 2 days. You know, closer to maybe 21 days at minimum. More. Yeah. Mm-hmm. And but I think it's also there's that, and then with chronic Lyme, there's all sorts of different approaches in terms of antibiotics, the types of antibiotics, combination antibiotics. If you're doing pharmaceutical antibiotics alone or in combination with botanical antibiotics, there's different protocols. And again, this is personalized medicine. So how is it manifesting in this person? You know, it can be neurologic, it can be musculoskeletal, it can be just inflammation everywhere. So we're going to kind of personalize it, customize it also to that person, and which systems seem to be primarily affected, as well as kind of getting to that infection piece. And you know, is that, like as Dr. Renaud said earlier, like, is there still an infection that we need to treat? Is it still there? Kind of what's, you know, is it something that has to be uncovered, or is it really we just need to kind of like support, again, the nervous system, the adrenal system, but it can like slow down gut motility. It can show up maybe the main thing is fatigue and brain fog. So how are we going to really support this person kind of for the long haul?
Yeah. The sad thing really, and nuanced, as Dr. Rose is saying, I think is the perfect way to explain this, because as I've said to many of my patients that I've treated for Lyme over the years, when they ask me sort of my approach or like, what's your protocol, or, like they're asking me sort of how I follow, is there certain like protocol of a famous Lyme doctor or something that's come up with protocols for Lyme or Bartonella or whatever, and what I do. The issue really is how you get treated. It depends on who you ask. Who you see as a provider, as a patient, will change your treatment, right? I might do things my way. Dr. Rose, you might do things your way. Who's right? Well, we're not right or wrong. It just might be differing of clinical experience, outcomes we've had, how we know to treat. And there are certain things that we have to understand about the patient too. If a patient has, say, chronic GI issues, am I going to give them 6 months of antibiotics? Well, gosh, I don't know. Is that going to make things a lot worse? Yeah, probably. Do they have co-infections, right? Am I just treating Lyme, or am I treating Bartonella? Am I treating Babesia? Almost every patient I've treated for Lyme does not just have Lyme. That's never happens. So you give doxycycline by itself for 2 months and they have Babesia. Well, Babesia is a parasite. That's not going to work. What does their detox look like? How nutritionally deficient are they? Do they have mast cell activation syndrome? Do they have mold exposure? It really it starts to just become this huge weight on the provider and the patient, and you really just have to start somewhere. But my patients that got acute tick bites, they always went on doxy, always, no matter if they had a bullseye rash or not. That's what the literature says. That's what the ILATS guidelines say, is if you get a tick bite, you go on doxycycline. Test the tick, send the tick into a lab that tests it.
Save the tick.
Yep, save the tick, send it into to a company that tests the tick. If the tick is positive, you need treatment. If the tick is negative, then you can stop the doxy. You're good. But the guidelines really support long-term treatment. But again, how long is that? The literature and the guidelines are mixed on how long you treat someone with chronic Lyme. Do you use antibiotics? Well, I don't know. There's antibiotic resistance. These infections are becoming more and more resistant to antibiotics the more we use them. So there's some studies that actually show giving antibiotics for Lyme, there's new data that says it actually strengthens the infection while you're treating it. So what's happening is the Lyme bacteria is evolving to become antibiotic resistant while you're on the antibiotics. Then when you stop the antibiotics, the Lyme bacteria is stronger than when you started. And it's like, well, gosh, I mean, it's kind of amazing from a science perspective, like how amazing this is, but scary that they can evolve so rapidly as you're trying to treat. So it is so complicated and so nuanced that it often drives everybody crazy, including, the providers, the patients. So you really have to understand, from my perspective, you really have to understand what you're working with as a starting point. You have to do really appropriate testing. You really have to understand if there's co-infections. You really have to understand what the patient can handle and how, and, transparency about the length of time it might take. It's all really important to know from the beginning.
So I would say that, to me, that would, if there's a question of the resistance to doxycycline or other pharmaceutical antibiotics, to me, that's a perfect window for some pretty potent botanical antibiotics. And as you well know, a lot of those are kind of broad spectrum and sometimes can even be antiparasitic. So
yeah, that was always my go-to. And there's actually studies that show if you use certain antimicrobials together in combination at the same time, they have potent effects against multiple tick-borne infections, actually working better than antibiotics.
Yep.
That doesn't mean you shouldn't potentially consider antibiotics, but you really have to understand what the studies show about how to treat. So, and everybody is so different. So, yeah.
But I think one thing is, and anybody who's, again, watching or listening and has dealt with this personally can kind of attest to this. Like you're in this for the long haul, right? Like anything, sadly, like a chronic Lyme, latent Lyme, like you're not going to get better in weeks or months even. Like it's going to, you kind of have to just be patient. And it's a real example of, this is not a bad thing, but it's a slow medicine. And that's okay. But it's just kind of what the expectations are.
Yeah. Yeah. And that's the other thing that is not conveyed with the conventional medical space. It's like, oh, we put you on Doxy, you're cured, you don't have Lyme. And then they come to me and I say the complete opposite. This is going to take you 2 years to treat. So it puts the patient in a very precarious place. Like, well, who do I believe?
Hold on, I want to ask a question there, because there's a difference, right? There's a difference between long haul Lyme disease and acute Lyme disease. Like, because you're going to treat someone differently who's, so like, okay, patient A got bit by a tick, they sent it in, they had the bullseye, okay, they take the rounds of Doxy, they caught it right away. But then you have the person who has been, had one of the tiny ticks that they never saw.
Sick for 10 years.
Yeah, years go by, they're sick, they don't know what's going on. Then they come into us or Med Matrix, and then we figure out they have Lyme disease. Those are two very different patients. Right?
Very different patients. Yep. Yeah, totally.
So let's start with patient A. Like patient A, they find a tick on them, they send it in. Okay, it has Lyme disease. They take the Doxy. How often are they just done? Like after the Doxy, they're good to go, or versus it's not taken care of and they need to, come to
I think it's often. I mean, I think if they've caught it early, and again, given more than the 2 days, more like we said, the
24 hours,
right? Then I think in my clinical experience, more often than not, it's kind of like that's background now. That's just part of their history, and they really don't seem to be having any residual effects.
Okay.
Yeah, so that's what the literature supports too, and I've seen that with my clinical experience is that if you every patient, like I said before, every patient that I ever had that got a tick bite that I was already treating, it's like they call me up, I got a tick bite. We gotta, you're gonna be on it. Did you save the tick? Okay, send it in. Blah blah blah. The literature says that if you start doxycycline within a certain period of time post tick bite, the likelihood of transmission significantly declines. Significantly. So if you have a really seasoned provider that you work with that can get you access to medication after a tick bite, you need to do it. That's what the guidelines say.
So definitely for a deer tick, but what about a wood tick?
Well, deer ticks are what transmit Lyme.
So like a dog tick, and that's largely why it's important to kind of just look at it under a microscope, know the difference, and then also send it in. And I will say, like for people who live in this area, I know that at least historically, the University of Maine had a service where you could send it in to their lab, and they'll look at it for you.
Yeah, most towns, like the public health department, has tick resources. Like you go on the Department of Public Health's website or something. There are tick companies. I won't name names because I don't work for them or whatever. But there are tick companies that do PCR testing that are very validated. But the thing is I want to be very clear. I've had patients say this to me all the time. Oh, well, it was a dog tick that bit me. So I'm fine. No, you're not qualified to make that distinction, right? Well, I know what they look like. No, you don't. No, you don't know what they look like.
Especially the little nymphs, right?
Right. I appreciate that you think you do, but I'm not taking a risk on your future health by just saying, oh, well, I'm going to write that in my note. Patient said it was a dog tick, so they're good. Yeah, no, that's not how this works. So you're going to get treated. If you don't want to be treated, then that's your prerogative, but it's not up to you to make the decision that you distinguish what type of tick it was. Well, it was on my dog. Okay, that doesn't mean it's a dog tick, So
there you go. Nice.
There you go. Yeah, they look similar, but it's like, oh yeah, it wasn't black, blah blah blah. Well, you're not qualified to make that assumption, right? This is your health, this is your livelihood. Just go on treatment. Let me take care of it, So, but there are patients that are very resistant to doing certain things, and they think they understand the differences, but it's always better to be cautious with this stuff.
Man, these things are so gross. I want to throw up.
And if you remove it, you want to try to remove the whole thing. Like you want to use a tool you don't want to just kind of pluck it off. And then you can keep it in the freezer until you figure out where you're sending it.
Yeah.
What if you just find it? What if you find what you presume to be a deer tick crawling on you? It's not in you, it's just crawling on you.
That's fine.
That's fine, but you
Okay.
want to check the rest to make sure there's not something else that is embedded / engorged. Yeah.
Okay.
Cole, do a search and put up a picture of the size of like a nymph tick or the other, like the sizes of ticks in different life cycles. And you can sort of see how small these things
Holy
can be.
cow.
Yeah, this doesn't really
man.
yeah, this doesn't really give the appreciation of size.
You're not going to see one this size on your body, right?
Yeah, you're not going to see one this size
right now. That would be like a horror
imagine?
movie, right?
That would actually make things easier. I mean,
Yeah,
super
it would.
gross. But that's
That
like
is-
living in Australia. You know, the insects are so big, you can see them from, but yeah, some of the ticks are so small that it makes detection really hard. And I've had patients tell me like, oh no,
this is crazy. That's
the tip of someone's finger. Yeah.
I'm looking at my finger right now. That is scary. Holy cow.
Yeah, you might think that that's like, you might be in the shower, right? It might be attached to you, and then you got your loofah and you scrub it and it just comes right off, right? You haven't even know it was there. Or it's in your hair and you just kind of like rub your hair and it falls out. I mean, people don't quite understand the magnitude of this, and that's the scary part. And like I said before, unfortunately, the medical community just doesn't show the seriousness of this, but thankfully with social media and the advent of technology, patients can connect with each other and really educate each other about this stuff. Sad, but it's a good thing.
Yeah.
We're gonna take that down.
Yeah, thanks.
Man, wow. All right. So what is like, because I guess what is like the long, we see a mix of patients. We see patients who want to optimize their health. They're already very healthy. They're 55 years old, 10% body fat. They're trying to run marathons. But we also see the patients who are, really struggling. And like for those patients, what are the kind of like symptoms that you might see that would start you thinking, okay, maybe this might be Lyme, as far as like long Lyme goes, or undiagnosed Lyme disease?
Talking about chronic. Yeah.
Chronic Lyme, yeah.
Yeah.
I mean, it could be anything.
Yeah.
So examples. When you say anything, like,
yeah,
what do you mean by anything? Like,
well, the migrating joint pain, the fatigue, brain fog. I mean, again, and then an older person, we're talking, they're, probably menopausal. If they're female, they might be dealing with other hormone, a man might be dealing with andropause, like low testosterone. So it's like, again, and it could be multiple things, right? It could be somebody who does have chronic undiagnosed Lyme and has mast cell activation syndrome and is menopausal, right? Like it could be just kind of multiple factors. But if there is kind of an undiagnosed chronic infection there, I feel like that, I think she will in the end do better if that is recognized and addressed as part of the comprehensive plan.
Gotcha.
Yeah.
Okay.
Yeah.
Are there varying degrees of long Lyme disease? Like let's say I was bit by a tick, 10 years ago. I'm otherwise healthy, but I get migraines. Like, could that be long Lyme? Or if you have long Lyme, it's like you're in rough shape?
Well, I wouldn't call it long Lyme, Cole. That's not. I would.
Okay, thanks for correcting me. What would be chronic Lyme? My bad.
Yeah, chronic Lyme, or just Lyme in general, just so people understand what we're talking about. Chronic. I mean, this is where history taking becomes really important, and even as a specialist, right? You have to kind of understand how to interview a patient. And this is where competent providers come into play as well, because does every patient that walks in the door that maybe has migraines, am I diagnosing them with Lyme? No.
Hopefully not.
Hopefully not, right? Do I have colleagues that do that? Every patient has Lyme, no matter what. Yeah. Is that reasonable? No, right? And the reality is that people get bit by ticks and they might contract Lyme, but it might not make them sick. So if you were to pull 100 people off the street and test them all, properly for Lyme. Would some of them be positive? Absolutely. Are they sick? I don't know, right? Maybe they struggle with certain things that could be related back to Lyme. Maybe they don't. Maybe they, as Dr. Rose is saying, maybe they have menopause. Maybe they're, have low hormones. Maybe their gut's dysfunctional. But to really put everybody in a Lyme boat, like everybody has Lyme if they have certain symptoms, is inappropriate, because then that's failure to be specific in diagnostics. But you really have to understand the patient. And sometimes it's not right away. Sometimes it might be, as Dr. Rose is saying, you have to sort of treat other things first. And then it's like, wow, this patient's really not getting better. This doesn't make sense. Tell me your history again. Like, where have you lived? What are you? Oh, yeah, well, this, that. I lived in Connecticut. I had a dog. Wait, have you ever had a tick bite? Oh, yeah, like 20 years ago, I had a tick bite. Now that you mention it, oh, we were ever treated? I don't think so. So sometimes it's not right away. Sometimes this is a couple of years of a relationship with a patient before you understand things, because it's not that simple, right? If a patient comes in and says, my chief concern is fatigue, that's a laundry list of symptoms that could be going on, right? It's not that simple to just say, oh, you have Lyme, let's treat it, you'll be good. It's yeah. But sometimes it's very, very obvious.
Mm-hmm. And then once you understand that someone has Lyme, is the answer always doxycycline, or like what?
No.
Okay.
No, I think we just, I think we said it can, sometimes it's different pharmaceutical antibiotics. Sometimes maybe it's not any pharmaceutical ones at all. Maybe it's a combination.
Right.
Yeah. And is that another advantage of functional medicine, where it's like you go to your, any doctor, like they're kind of, their toolbox to treat Lyme is pretty small, while it's like you guys have a lot more strategies to actually take care of something like that.
I think so. I mean, even if in treating something that's an infection, I think we have a larger toolbox.
Yeah. I think functional medicine providers, I have a lot of colleagues they've sent patients my way because they're like, I don't know how to treat this. You have done this, you do it. But functional medicine providers have a better way to assess a patient from a whole person perspective, right? They can do a lot more to try to understand their body and what's going on, but they might not be a Lyme literate provider. And is that a problem? Well, it depends, right? It depends on, do they need hardcore treatment, right? Mm-hmm. Or do they just need supportive things that can make them better, right? Aiding their body's ability to heal itself. If the patient does need botanical medicines or antibiotics or both or other things, if a non-literate provider is treating, then it might be a problem, right? Mm-hmm. They might be a functional medicine provider or something similar, but they don't understand botanical medicine. They don't understand natural medicine. They don't understand Lyme. So it's tough sometimes.
Gotcha. Yeah. So I'm learning so much about Lyme. I hope everyone in the audience is learning. We have a lot of people who've actually stuck around. We've about probably 26 on YouTube and probably the same amount or so on Instagram. I actually have no clue. But I can't see that from my screen. And guys, we appreciate the comments. We're going to do some Q&A at the end here. So if you have comments, questions, definitely drop them in below. We love all of you who are interacting. We appreciate it. We're also going to dive into some actual patient cases too. If you want to stick around for that, we're going to be getting that inside 10 minutes. I guess probably like one of the burning questions, I just did a quick Google search, just kind of to represent what the average, understanding of the consumer would be. Yeah. And this was probably the most reputable source I could find, the top Dartmouth, saying 50% of adult ticks carry Lyme disease. Is that so? If you get bit by a deer tick, is it like 50% chance that you're going to have Lyme disease? What's your clinical experience, guys?
I mean, I don't want to say a percentage, because that gives a false sense of something. It's a lot of ticks carry infection. The tick actually gets infected from feeding on a mouse or a bird. That's where the tick gets the Lyme from, and then the Lyme, is transmitted to you. So the thing I want to make very clear, maybe this is a good time to talk about these other things, is it's not just Lyme, it's the other types of infections that are in ticks. So we call them co-infections. Lyme is like a tick-borne illness, right? Like we say Kleenex or Tylenol, right? We kind of use this term as a catch-all phrase for different types of infections, but there are other infections that ticks carry, and actually other vectors that carry tick-borne illness. So a perfect example of this is something called Bartonella, which I've also treated a lot of. Bartonella is considered a co-infection of Lyme. It's not Lyme. It is a separate bacteria. It can be transmitted via tick, but more than likely, Bartonella is transmitted via something else, a cat, a dog, a lice, a fly, bed bugs, sand flies. Bartonella is what causes cat scratch fever, if anybody's ever heard of cat scratch fever. So you don't have to, you can't really put a percentage on these things because it's not that simple from a Lyme perspective, because there's other things in there, not just Lyme. So that's where it gets complicated, and that's how treatment gets complicated as well. To our point earlier, when we're saying, well, go on doxycycline and you're quote unquote cured. Well, no, if you were infected with another infection that's not necessarily Lyme, that doxy's not going to do anything. So it really complicates things, the co-infections. And to be perfectly honest, I think co-infections are what drive a lot of Lyme cases. And there's some literature actually to support that really patients are struggling with co-infections more than Lyme proper. So
Gotcha.
Yeah, it's a huge part
and the
of
co-infections, are they just as bad?
Yes, if not worse. Yeah. The most common are Bartonella, like I mentioned. It's a bacterial infection that is transmitted by ticks, but also other things. And then there's something called Babesia, which is a blood parasite. Talk about heebie-jeebies. Babesia is a parasite. It's not a bacteria. Most often transmitted via tick, but can be transmitted via mice too. So if you have Babesia and you're trying to treat with antibiotics, well, forget it. It's not going to do anything. So and this is where the medical community gets lost, right? They're not testing for these things. They're not even evaluating for the likelihood of them being there. They're not making a consideration for it. So yeah, it can really complicate treatment outcomes. That's why proper testing is really important. That's why you need a literate provider to understand all the nuances. It doesn't make it easier to treat, but if you can on paper say, I found these things, we know what to do now, it's a huge step forward in the healing process.
Sure. Yeah.
Yeah.
So most doctors, if any, won't even test for these co-infections.
No, very rarely, very rarely. And if it is done, it's again a Western blot test, very inaccurate. They need proper testing.
Jeez.
Yeah.
Very scary. Scary stuff.
Yeah, unfortunately.
Yeah, let's look at the brighter side of things. Let's talk. Hopefully you guys have some patient success stories on how you treated Lyme. So, Dr. Rose, why don't you go first with any Lyme patient case studies you have and kind of your approach?
Yeah. This was a woman who was, I think she was 35 when we started working together. She came to me she already knew she was positive for Lyme. She had been, I don't remember exactly who or how she had been diagnosed, but we kind of knew that already. So that kind of made my job a little bit easier in terms of the testing. She was, tired, brain fog. Now, of course, she was also 35-year-old woman with 3 children, working full-time job, like youngish children, like, how much of the fatigue was also just like her life situation, maybe part of it, but it was definitely like never well since that tick bite. Like it was pretty clear. And I think we do see that oftentimes with infections. Like when you, as Dr. Renaud was saying, like when you do a thorough health history, it's like, if you really get into it, people can usually kind of pinpoint when there was a shift as opposed to some of these other multisystemic things. So, a year prior, she was like, I kind of remember the tick. I'm not really sure, but it was definitely like pretty, like I got sick, I got the flu. And so she was just dealing with kind of odd neck pain. I think it was primarily her neck that would kind of come and go, but it was mostly the debilitating fatigue. And she was really, really sensitive to changes like how she was eating to the amount of sleep that she had. And that hadn't been the norm for her before. So she, in particular, this particular patient really was not interested in any pharmaceutical antibiotics. She, I don't honestly remember her reasoning, but she was just kind of like dead set against that. So I just approached it mostly with from a botanical perspective, some pretty strong herbal antibiotics. And as always, just making sure that kind of like those detoxification pathways were optimal for her. So when I did start to work with her, it really was a lot about managing like optimal sleep, nutrition, just kind of pacing herself, like not overextending, not overdoing it. And I remember she was, and again, this was months, a treatment that went on for months, and she was doing really well. And then she traveled to Europe with her family for a few weeks. And of course, when you're traveling, you can't always control when you're sleeping, what you're eating, etc. And she came back pretty debilitated. Like it felt like, it had been 2 steps forward, and then this was like a pretty significant 1 step back. And it took us a little while to get her back, but over the course of 6 to 9 months, it got to the point where, again, it was gradual, but I would say like her resilience improved, right? Where like she still couldn't go a night with like 2 hours of sleep, but she didn't have to be quite as rigid with her sleep hygiene, her nutrition. And I think when I stopped working with her, she was pretty good. I don't know if she was like 100% back to before the tick bite, but it was definitely in the high 90s. So slow and steady.
Gotcha. Thanks for sharing. Dr. Renaud, do you have any questions about that? If not, we'd love to hear a couple case studies.
No questions. I've had a lot of similar cases, but I have actually a similar case of a patient. She was around the same age, like mid-30s, and it was very clear. She got it. She was a personal trainer. That was her job. Very active. Really no health issues. She got a tick bite. I think it was 4th of July weekend, if I remember her story right. And she got acutely sick. I was just trying to remember. I don't think she actually went to see anybody. Like she didn't go to urgent care. She didn't see her doctor. Kind of got over it. And then in the coming months, the debilitating fatigue, she had to quit her job. She couldn't train people anymore. She had to, she had to leave her relationship because it just ruined her personal life. She had to move back in with her parents. And the sad part about that was she moved into their basement, which was infested with mold. So it just made things so much worse. She became suicidal. I had to get her out of that house because the mold was being it was a huge issue on top of everything. We were able to do, similar to Dr. Rose's case, we were able to do some botanicals. She was very sensitive. She also had laboratory confirmed mast cell activation syndrome. So she was very sensitive to a lot of things I gave her. And it really complicated things, and the mold complicated things. But after 2.5 years of just slow and steady, introducing little things here and there, we did some IV stuff, some ozone. We did methylene blue, which is a whole nother podcast we could do on what methylene blue is. It's a synthetic dye that we use in medicine for certain things, but it has anti-Lyme properties, and also anti-aging properties. So methylene blue, herbs. We also did something called SOT therapy, or supportive oligonucleotide technique, which is an IV therapy that genetically alters the Lyme bacteria. That's a whole nother case. I won't get into the specifics of that. That's a lot, very complicated. And finally, after 2.5 years, she got her life back. She went back to work. Nice. So it was just it was so slow. It was just slow. But what you're looking for, and these cases just illustrate this is not a linear path to being well. This is what I've always called a staggered linear progression. Right, you're going to take two steps forward, then you're going to take 1 step back, then 3 steps forward and 2 steps back. It just is. It's not straight to the finish line. So,
man, that's a great story, both of you guys. Especially, the way that health can affect your life is pretty dramatic.
Yeah.
And the sad part is, a lot of patients, they go sometimes the rest of their life, kind of getting, I know we have patients who in testimonies said they felt like they were getting gaslit, they weren't, it wasn't getting addressed.
Well, these are invisible illnesses, right?
Right.
They don't look, nothing wrong. Oh, you look fine. You look fine. Maybe you're depressed, right? Or maybe you're anxious.
Yeah.
The physical exam is normal. Well, I don't know. You look okay. To me, it's like it's an invisible illness. How do you quantify how tired you are, right? How do you quantify how brain fogged you are to a provider? There's no blood test that, oh yeah, look at how fatigued you are on this blood test. That's not a thing.
Sure.
So it can be really hard to be believed. So people live in invisible, they live indoors for years struggling. And I hate to say it that way, but it's unfortunately true. So it's really good that we can do stuff like this to bring awareness to people that are struggling.
Yeah.
Yeah.
All right, we're at an hour here, so let's move into some Q&A. So guys, if you're live with us and you've been with us, let's do some questions. We have some already. We're going to get as many as we can. The earlier you comment, the more likely we are to answer your question. So let's start here with this one. And I'll let you guys just read it.
Oh, yeah. So, yeah. Red meat sensitivity.
Alpha-gal.
Alpha-gal. Yeah, there's a certain tick-borne illness called alpha-gal that if it infects you, you become very insensitive to red meat, to the protein in red meat, and it can cause people to not be able to tolerate red meat anymore. It makes them very sick. It's very, very, very weird.
Yep.
Yeah.
So the answer is yes.
So the answer is yes.
Okay.
Yes.
Great.
Yeah, there's some questions about dogs. Yeah. That's one thing is veterinarians understand this beautifully.
Better than a lot of
I've had a lot of patients
doctors.
actually that are veterinarians and they get it. They're like, oh yeah, Bartonella, Lyme, like I know what that is. Totally.
Should we read the question?
Yeah, Lyme in dogs, positive heartworm results. Humans end up with Lyme issues or heart issues from Lyme. Yes,
you can. Yep.
You can.
Lyme carditis. Lyme carditis. Yep.
Yeah, where the
Pericarditis.
bacteria. Yeah, the bacteria can invaginate itself into the heart muscle, cause arrhythmia, cause issues with the pacemaker, the natural pacemaker. Yeah, actually, very well recognized by the medical community.
All right.
Yeah.
Another one.
I was bit
several times by deer ticks in the last 20 years, following years of exhaustion and joint pain and brain fog. Had one test many years later. I'm assuming that later test was positive, but that's not an uncommon scenario.
Yeah.
Yeah.
Labs. Where do we send labs? So, like I said, there's a couple labs that I use. The most common ones I'm using for Lyme disease are IGeneX. There's also another company called T-Lab. Those are the most commonly used fish testing labs that I use. But again, that's something you'd need a literate provider to do for you. That's not something patients can do on their own.
Mm-hmm.
Yeah.
What about mycoplasma? Are any of these co-infections curable, or will you always show a positive?
Yeah, mycoplasma is a common bacterial issue that can invade the lungs. That is very common as seen with Lyme. So a lot of patients that have Lyme can also have mycoplasma. They can kind of go together. Are these infections curable? Technically, from what we think, no. I can't prove this. There's no data to prove this in the medical literature. However, Lyme disease and the co-infections of Lyme, we think act in the same way as viruses do. Basically, they stay with you forever. They're not viruses, I'm making that very clear, but they stay with you forever. But the goal is to get them in a remission state. Like they are put in a corner, not doing anything, and your immune system takes over. And sometimes people test positive long after they've been treated. That is not unusual either.
Cool. Anything to add, Dr. Rose?
Nope. That was well said.
All right, we're going to keep going. Let me know if you guys are running tight on time.
Yeah, a
Do
couple more
minutes
is
here.
What test could be done if it was over 20 years ago, or is what's the $2,800
$2,800.
$2,800
Yeah.
test to confirm? Well,
Yeah.
go ahead. I mean, it's still going to pick up those antibodies. Potentially.
Yeah, potentially you can do antibody testing, but again, that's not going to tell us anything. Fluorescence microscopy or fish testing is the gold standard of infectious disease and tick-borne illness diagnostics, and it will pick up something that's decades old. As long as it's in there attached to the red blood cell, it will be positive.
And what about, like, I've done Google testing for Lyme disease before, just for patients who've asked, and you can find lab Lyme panels that'll look at like 50 of there's so many different co-infections. Are those, and they're like $200? Is that real, or is that like a BS
Yes,
test?
it is real. So the thing about testing is that fluorescence microscopy testing is not advanced enough yet to look at all the different species. So when we are questioning other species of Lyme or co-infections, we really have to use other testing methodologies, whether it's PCR or Western blot. The technology is just not there. But it's getting there. The labs are advancing. But to do all the different species, it's just not there yet. So you have to use other methodologies and kind of do the best you can.
Gotcha. All right, we got some people asking some specific questions about like treatments for Lyme. I don't know if you guys can see those comments. So we can't give you guys like medical advice, but what we'll do is I can just say the treatment for Lyme, and if you guys can play a little game, rank it 1 through 10 and kind of explain why you feel that way.
Okay, go for it.
All right, let's ivermectin for Lyme disease.
No.
So is 10 what's the scale?
10's great. 10's like, if I have Lyme, I'm doing that. 0's like, I would never do that if I had Lyme. So ivermectin.
Ivermectin has been used to treat babesia and may help with the immune response in relation to treating Lyme. It is not a first-line treatment of Lyme.
Okay, gotcha. Colloidal silver supplement. No.
That's probably low on my list.
Low on my list, yeah.
I think I saw someone say strawberries. I don't know if that was out of context. What do you think about a high strawberry diet for Lyme disease?
I don't think that's out of context.
I don't know what the evidence is on that one.
Yeah, I think that's out of context.
Okay, gotcha. Man, a lot of really great questions, guys, here. Good work. We're going to wrap them up soon. So if you have a question, shoot it now.
Is red face and swelling a symptom of Lyme? Not necessarily. You can get swollen lymph nodes from Lyme. That's a common symptom acutely, but I wouldn't say red face.
That could be a lot of other things too.
Could be a lot of other things. Yeah, I don't know. Is Lyme or any co-infections transmittable from mother to fetus? Ooh, this is controversial.
I think it is possible, isn't it?
It is possible. Yeah. So babesia, the co-infection babesia, the parasitic infection, we do have data to show that it is transmittable. Lyme is not as clear. The data does not support it, but it has been shown, but it's just not, there isn't great data to support that it can, but certainly if you can transmit other things, viruses and why can't, and I've been asked the question a lot is, I have Lyme. Well, can I give it to my girlfriend? We have unprotected sex, or whatever. And that's another thing. We can't definitively prove that one way or the other. It's hard.
So err on the side of caution on that one, probably. Yeah. Okay. All right, that's it for questions, and then we're just gonna end it with a quick fire round. It's literally just myth, or I came up with like 10 questions. It's just myth, or it's gonna be fun. Fact. And I'll rotate between you guys. So Dr. Rose, Dr. Renaud. Sound good, guys?
Okay. Yep.
All right. You always see a bullseye rash if you have Lyme.
False.
If your Lyme test is negative, you definitely don't have Lyme.
False.
Lyme disease is easy to diagnose.
False.
Lyme, for an hour. Lyme only exists in Connecticut and the Northeast.
False.
All right. You have to see the tick bite to get Lyme.
False.
Okay. A short course of antibiotics cures everyone completely.
False.
Chronic Lyme isn't real.
False.
If your symptoms are neurological, it can't be Lyme.
False.
Joint pain is the only major symptom of Lyme.
False.
Ticks have to be attached for 24 to 48 hours to transmit Lyme.
Totally false.
Okay. You can't get Lyme in the winter.
False.
Once you have Lyme, you can't get it again.
False.
False. Lyme disease is just Lyme disease is just fatigue and body aches.
False.
Oh boy.
If you're okay, 2 more. If your symptoms come and go, it's probably not Lyme.
False.
All tick-borne illnesses are the same as Lyme. Last one.
False.
All right, guys. That was an awesome episode. I learned so much. I don't know about you guys in the audience. Those are some great questions. We're gonna take us home here. I guess, Dr. Rose, Dr. Nard, if you guys can kind of just quickly explain, who would be a good patient to come see MedMatrix looking for helps around these sort of things.
Well, I think it kind of became clear that usually people who it would be beneficial for them to come in, it's not clear cut, right? You're usually coming in, you have more than one symptom, you have more than one part of your body is being affected. It's not clear cut, and maybe there hasn't been a clear diagnosis yet. You just know that you don't feel right. And maybe you've seen other providers, maybe you haven't, but it's you just know that something isn't quite right, and you deserve to get some answers, and you want kind of a different approach. I think we're here. It might take us, a lot of, again, in-depth questioning and looking at labs, but we will work with you to try to figure out what's at the root what's at the root of what's going on.
Yeah, I mean, I couldn't say it better. If you're struggling and something's wrong, don't take your healthcare team's word for it. You know your body, you know what you're struggling with. If you've been told, this can't be, or that's not possible, or never, some of these very final negative statements, don't accept that. Do your own research, listen to podcasts, watch webinars, educate yourself, talk to other people. There are resources out there for you to get help. This isn't an easy thing to treat, and I think we've made that very clear, but there are people all over the world that do have knowledge of how to do this. So it's trying to find people. So try to do your research. Like I said, watch webinars, listen to podcasts, you know your body, and don't accept no as a final stop if you're struggling.
Awesome. Thank you guys. And yeah, for those who joined us live today, we have a super special thing for you guys. I just pasted a link into the comments as well as a QR code on the screen that you can see if you're on YouTube, maybe on Instagram. You would actually get $200 off as a new patient if you book your free initial assessment through that. The reason we don't ever discount that much, the point we discount that much for the webinars is because we want to encourage patient education, patients who come to the table educated, or patients who get better results faster. So we appreciate you guys educating yourselves and taking the time. So that's our thank you to you. It won't be valid for another probably until 7 p.m. So you have exactly 1 hour. So if you're at all interested, click that link right now, copy and paste in your browser, book a call with our team, see if we can help you. And if we can't help you, we want the end result to be that you get better. So we will do our best to kind of point you in the best direction as a patient. So with that said, Colin, one last thing, take everyone home. Dr. Nard, if someone gets a tick bite, what should they do?
They need proper treatment. They need antibiotics. That's what the literature says. That's what all the
I'm looking for the procedure,
Lyme associated. You need to
send the tick
I'm not going to give specifics, but you need to send the tick in to a reputable lab to be tested, and you need to go on proper treatment right away. No questions asked.
Perfect.
Yeah.
Awesome. Thank you guys so much. I know we went over. Everyone appreciates it. We really appreciate you guys. Thank you so much. Thanks everyone for joining.